So the reason for the virtual consultation has really been driven by the added attention to patient time, valuing patient time, trying to reduce the travel for the people in more distant parts of our catchment.
I've been using it with patients in Blenheim now for about 5 or 6 years. I think it's a symbiotic relationship. It's good for the patient and it's good for me. Blenheim's an hour and a half away. From my home it's 2 hours away, so that's 4 hours in a car. And for the patients who don't have to travel an hour and a half to Nelson from Blenheim, it makes perfect sense.
So far I've only had one patient that I've used this with, but certainly for her it's been very successful. She lives in Golden Bay, so she really needed, like if she lived in Nelson she would have had weekly sessions, but I only go over to Golden Bay once every 2 months. So after the initial face-to-face consult we were able to do some weekly sessions via telehealth, which gave her a more equitable service as to someone who might be living in Nelson.
The actual consult is the same as if the patient was in the room. The preparation was more in the technology, making sure I knew how to get the link open, get the actual system running, and then positioning. Actually had to think more about positioning in the room so that I could have results on one screen and the patient on the other, and I was looking at the patient and the camera. The sort of setup was the preparation. For me, the actual clinical time is the same as any other clinic.
You need a different approach as a clinician. You have to be prepared for the clinician's consult before the patient comes in the room. Often when a patient's with you, you can spend time looking at a computer, rummaging through the notes, but the only engagement you have with the patient is with the eye-to-eye contact through the video screen, and therefore you have to be prepared for the consultation before they come in the room. I traditionally would dictate a letter to the GP in front of a patient, but I've realised that also kind of disengages the patient if they're on a screen, so I don't do that anymore. So you have to be very focused, talking to the patient on the screen, and make it all about them.
The quality of the sound in particular is really important, and so that has probably been one of our biggest limitations with trying to use telehealth for speech-language therapy. So particularly if you're working on voice, which is one of the things that we do, sometimes it can be hard to know, if you're hearing something not quite right with the voice or if it's actually just a glitch in the sound. So it does need to be quite high quality, and you need to have good stable sound and picture as well.
I think it traditionally works better for a follow-up consultation where you've met the patient, you've sort of created a rapport, you have a relationship, and you're following them up. And I think often that's ideally suited to a Skype conversation.
I've found them working very well in Golden Bay for patients who I know and who know me. So I've decided I won't do any new patients as a virtual consultation, and I'd have to know the patient very well if I was having a difficult conversation down video.